The coronavirus disease 2019 pandemic has caused catastrophic disease around the world. Severe lung involvement with acute respiratory failure is the most common complication in COVID-19, but many patients have complications in multiple organs, including the heart. Many investigators from different countries have recognized an inflammatory syndrome in children that is similar to Kawasaki disease, a rare syndrome known to affect children that can cause coronary artery aneurysms. It is a rare condition usually seen in children under the age of 5 that causes high fever, rash, and inflammation of the blood vessels. This new disease has recently been named as pediatric multisystemic inflammatory syndrome, temporarily associated with SARS-CoV-2, and until now it has affected around 100 children in the United Kingdom, with new cases in Europe and the United States. The purpose of this video is to review and inform about this disease in order to know the differences between the pediatric multisystemic inflammatory syndrome and Kawasaki syndrome, while also explaining its relation with COVID-19.
Now I'm going to talk to the physiopathology of Kawasaki disease. This physiopathology is not well understood. I told the clinical and epidemiological feature of this disease, such as an infection cause. One hypothesis is that it's caused by ubiquitous infection agent that causes disease only in certain genetically predisposed individuals, particularly Asians. Another hypothesis is related to the superantigenic bacterial toxin due to the presence of the expansion-selected BV2 and BVH receptors of T lymphocytes, where, however, it is a controversial theory. Amazing immune alterations occur in acute stages of the disease, including a marked stimulation of the cytokine cascade and activation of endothelial cells. The key steps leading to the coronary arteries are still under study, which is clear the activation of endothelial cells, CD6H monocytes, macrophages, CD8 lymphocytes, cytotoxic, and IgA oligoclonal plasma cells seems to be involved. The prominence of IgA plasma cells in the respiratory tract, similar to the finding found in fatal respiratory viral infections, such as a portal of entry by airway of a etiological agent or agents. Enzymes such as matrix metalloproteinases are capable of demanding integrity of the arterial wall, which is important in the genesis of the coronary aneurysms. The factor of vascular endothelial growth, activating factor of chemotactic monocytes, factor of tumor necrosis, and various interleukin seems to play an important role in the vascular process.
The Kawasaki-like disease's clinical profile generally divides itself into 3 phases: acute, subacute, and covalence phase. Acute phase. It presents constant fever above 38.5 degrees Celsius, diarrhea, vomit, abdominal pain, loss of appetite, cough, redness, and swelling in the palm of the hands and feet. 90% of patients present bilateral conjunctivitis days after the onset of the fever, mucositis causing cracked, red lips with inflammation of the tongue. This last symptom is also known as strawberry tongue. 70% of patients present rash, lymphadenitis, and even toxic shock. The main difference between this disease and the Kawasaki syndrome is that the Kawasaki syndrome can lead to arthritis in around 10% of patients. Subacute phase. This phase starts when the fever disappears, usually around day 10, lasting until the 4th or 6th week. The most characteristic manifestation of this phase is the peeling of the fingers' skin that spread through hands and feet. It can also present aneurysm in coronary arteries, which is caused by the inflammation of the blood vessels, thrombus, and high levels of inflammatory markers such as PCR and troponin. Covalence phase. In this phase, the symptoms resolution occurs around the 3rd month. The Bowes lines are present during this phase. The coronary arteries aneurysm usually heals spontaneously, but if there is presence of bigger aneurysm, it's possible they can expand or even provoke a myocardial attack.
Children have to date borne a minimal medical burden in the global COVID-19 pandemic. Epidemiological data from many countries show that children are a small minority of those who test positive. Recent studies affirm that children younger than 18 years have made up only 1 to 7% of national cases in the USA, just 1% of cases in the Netherlands, and a 2% of a large observational cohort in the UK. This confirms that severe illness and death due to COVID-19 among children are rare, with accurate estimates unavailable because of an absence of true population denominators. Attention has now shifted to the vulnerability of children for two reasons. First, the degree to which children transmit COVID-19 is the key to how countries reopen communities after lockdown. Second, new concerns about a novel severe Kawasaki-like disease in children related to COVID-19. Clusters of children from UK with this inflammatory syndrome had acute febrile illness with evidence of single or multi-organ dysfunction. Laboratory features were neutrophilia, elevated CRP, and clinical features include abdominal pain, gastrointestinal symptoms, myocarditis, and shock. There could be different explanations for the possible association of COVID infection and KD. In PCR negative antibody positive cases, it's quite possible that coronavirus infection in recent past can trigger an immune response simulating KD. COVID-19 is also known to cause excessive inflammation and cytokine storms like KD during an active infective.
Most children with the MIS-C need to be treated in hospitals. They need to be in close observation, and a small number may need to be in intensive care. A pediatric specialist in infection disease, a rheumatology, a critical care, and a cardiology can anticipate and address the different aspects of the illness. The treatment usually involves supportive care and a measure to reduce inflammation in any affected vital organs to protect them from a permanent damage. So the supportive care may include, if levels are too low, like a dehydration, the supportive care will be fluids, an oxygen to help with the breathing, blood pressure medication to normalize the low blood pressure related to a shock or to help with the heart function, a breathing machine that is a ventilator, the medications that reduce the risk of blood clots. The blood clots is a mass of fibrin and blood cells formed by the coagulation of blood. And the medications will be such as aspirin or heparin. The treatment, it includes to reduce the swelling and inflammation. So an anticoagulation to curb blood clotting. As well, it will be the intravenous immunoglobulin. This one is used to be treated the Kawasaki disease. And it will be an anti-inflammatory drugs. It will be the corticosteroids and drugs blocking the interleukin-1 and the interleukin-6. Other treatment may be used depending on the results of the laboratory. The children with serious cardiac complications will we need to follow over time with repeat echocardiograms to monitor the heart and the coronary arteries.
In conclusion, since this disease is relatively new, it is important to observe the patient's improvement during the course of the disease so we can provide an effective and adequate care when needed.